Impressions in complete denture. Basic requirements for impression making are knowledge of basic anatomy, knowledge of reliable technique, knowledge and understanding of impression materials, skill and patient management. The objectives of impression making are preservation of remaining structures, retention, aesthetics, stability and support. It is remembered by a mnemonic called PRESS. P for preservation, R for retention, E for aesthetics, S for stability and S for support. Let's move on to the terminologies. Impression is nothing but a negative likeness or copy in reverse of the surface of an object. In complete denture impression, it includes the recording of entire denture bearing, stabilizing and border seal areas in edentulous mouth. Preliminary impressions are used for diagnosis, treatment planning and for construction of special tray. Secondary impressions are used for making of final prosthesis. Border molding is nothing but the shaping of denture borders to mold the depth and width of the sulcus. It's otherwise called as peripheral tracing or muscle trimming. Now, impressions in complete denture are classified based on the theories of impression making, based on the technique, based on the type of impression tray used, based on the impression material used, and depending on the purpose of the impression. What is the difference between primary and secondary impression materials? Primary impression materials are alginate, compound, plaster, and putty addition silicone. They are essentially used for construction of special tray. Primary cast is used for construction of special tray. Secondary impression materials are ZOE impression paste, monophase addition silicone material. Depending on the theories of impression making, we classify CD impressions as mucostatic, mucocompressive and selective pressure. Coming on to the first technique, which is mucostatic or passive impression technique, it was first proposed by Richardson and later popularized by Henry Page. The impression is made with oral mucous membrane and jaws in normal and relaxed condition, and border molding is not done here. The impression is used with an oversized tray, and the materials that are used with mucostatic impression materials are alginate and impression plaster. Mucocompressive impression technique, on the other hand, records the oral tissues in functional and displaced forms. The materials used for this technique are impression compound, waxes and liners. Apart from that, we also use impression compound and putty addition silicone. Selective pressure impression technique was suggested by Boucher, and according to this technique, it makes it possible to confine the forces acting on the dentures to the stress-bearing areas. The special tray is constructed in such a way that non-stress-bearing areas are relieved and stress-bearing areas are allowed to come in direct contact with the tissues. The materials that are used for selective impression technique are ZOE impression paste and monophase addition silicone. Then we have open mouth versus closed mouth impression technique. Depending on the purpose of impressions, impressions can also be classified as diagnostic impressions, secondary and primary impressions. Now, before making the impressions, we ensure that proper examination and conditioning of the patient and mouth is done. A complete case history is taken. We do a thorough clinical examination, identify and correct underlying adverse conditions, and we identify the factors that complicate the impression making and find out if the patient is an old denture wearer. If the patient is an old denture wearer, we ensure that the patient is remove his dentures 48 hours before impression making for the tissues to come back to its original form. The steps involved in impression making are preliminary examination of the patient, seating the patient, selection of the tray, selection of the material, and making the impression, primary impression, followed by border molding and secondary impression. This picture clearly shows you the positioning of the patient in upright position and the position of the operator. For maxillary, the doctor stands behind the chair or at 11 o'clock position, and for mandibular, the doctor stands in front of the patient or at 7 o'clock position. This picture shows you how preliminary impressions are made with the help of stock trays. In case there is inadequate adaptation or extensions of the stock trays. You can extend it with the help of utility wax, or in case of high volt pallet, you can extend the palatal depth with the help of wax, so that the void in impression is avoided. Pliers can be used for adaptation or for customizing the primary impression trays. You can use pliers, adjust it so that the trays adapt according to the oral tissues inside the mouth. Once the primary impression is made, we pour it with plaster and obtain the primary cast, and we start constructing the special tray. We block the undercuts. The special tray, we ensure that it is fabricated 2 mm short of sulcus, so that we provide space for the border molding material, and we construct it either with the help of light cure tray material or self cure tray material.